Um, Hello again, my colleagues. Today I will start about 2 to 3 lecture of radioactive isotopic scan. First of all, um, I feel that we are more than family in this group. So I tried to invite many of my isotopic nuclear specialists, but finally no one has enough time. So I assign myself to prepare this lecture, and as any radiologist, I'm not expert in isotopic scan. However, I'm doing my best to help all of you because, according to Dr. Nahla, when she create her group, and even me and Dr. Ismail, all of us are targeted help for our colleagues to pass the FRCR exam. So um, I will do my best in another specialty like this, and I hope all of you get benefit. Uh, if anyone has a better information in any part of the lecture, have any note, please any text, send message. Okay, because especially the renal isotopic scan has a lot of complex information. Anyway, let's start our session. By the way, what I will do to be aware, I will I will run the session like the usual, case by case. And for example, this is a renogram. After this case finished, I will give some notes about the normal max 3 and the curve, everything. Okay? I think in this is more reactive, more interactive, and more interesting. Let's start with our first candidate. I think my voice is audible, the image is good, everything is good. Okay? Okay, my colleague. Uh, First candidate, are you ready? Yes. Yeah. See, this is 65 male patient recently diagnosed with hypertension and stroke. Okay? They have a doubt about the renal artery. What is this? I will show you. What is this? What is this? What is this? What is this? Tell me, what is the name of this study?
The study MAG 3 done by technician 99M uh,
What is magistry? Renal or scan or bone scan?
renogram renal scan.
Yeah. So renal max re nuclear study. Okay.
Okay. Yes.
Renal again. No see today, my colleague, no problem. Whatever, this is our first nuclear lecture, so don't worry. Whatever mistakes you will do, it is acceptable. Again, the name is renal because we see the kidney, and the tracer is max 3, and finally nuclear study. Renal, renal max 3 nuclear study. Doctor, why this is not DEMSA? Why?
Because it's dynamic, multiple images.
Excellent. Excellent. So my colleague, I see time 0 second, 16 second, 10 minute, 40 minute. So this is dynamic. DEMSA not used. Okay, doctor. Another question. Doctor, Max 3 can measure the split renal function or not?
Yes, you can bet renal function. Yes,
Okay,
excrete renal function. Yes.
excellent. Can Max 3 measure glomerular filtration rate?
Yes.
No,
Yes.
no, because it is excreted by glomeruli or tubule, distal tubule. Okay,
Mm.
okay. See,
Yes.
don't worry. We are giving some information. Again, my colleague, Max 3 is absorbed and excreted by the kidney. So it is used in dynamic. Okay, but which part of the kidney excreting the max 3? The distal collecting tubule. So Max 3 can measure the renal function, even the split renal function, everything, but not the specific tracer to measure GFR, glomerular filtration rate. Why? Because it is not excreted by the glomeruli. Very clear like this. Doctor, DEMSA can be used as a dynamic or not?
I think no.
Excellent. Why? Because it is not excreted by the kidney.
Tubules.
It just the DEMSA, my colleague, the other tracer, just uptake by the renal cortex only and not excreted by the kidney at all. So DEMSA is not used as a dynamic. DEMSA is not used to measure the renal function. Okay, this is just a startup information. Doctor, this patient, we are in a big doubt about renal artery stenosis because he is hypertensive. Yeah, look with me. See, this is right or left, and this one,
Left.
right or left?
So this is one is posterior imaging.
Excellent. So this
This one is left.
more than excellent. My colleague, this is a second or one of the most important. In renal scan, the patient is in prone position. So the left is your left. This is your left. This is at your left. So this is left kidney. This is right. Doctor, yalla one by one, one by one. Mm. Tell
I
me what happened.
firstly I can in the first images to the upper left I can see that there is decreased perfusion seen in the left kidney and there
Okay.
is normal perfusion at the right kidney, but there is an excretion and there is a contrast uptake is seen in the renal pelvis, and both ureters are seen in the last image in the first row.
Okay.
A normal excretion is also seen in the renal bladder,
Excellent.
but there is a delayed contrast excretion seen in the last images in the last row at
Really?
the left kidney and the renal pelvis.
1 second, 1 second. See my colleague to follow what our brilliant colleague said. Here, less tracer uptake than here, and even here, and here. Look at the kidney at all. This is the pelvis, by the way. Look at the kidney as a whole. Okay? It is obvious here is less than here. Then, then the excretion of the urinary bladder start from here. No problem. The most important, I will show you one image. What do you think about this one? Oh, no, this one. For example, here. What happened here? Could you tell me?
At this stage, after 25 minutes, there is total excretion of the left kidney, but is still
Brilliant.
secretory
Brilliant.
process in the right kidney, in
Could,
the left kidney.
could we go backward? Here. The excretion of the right kidney, nearly complete excretion, at least here, 19 minutes. Okay? Are you agree with me?
Yeah.
Yeah, but still here persistent the same amount. See my colleagues, from the beginning, the left kidney take just a small amount, a small amount. The same amount is still catch or persistent within the same left kidney. So we can consider the complete excretion and the clearance in the right kidney at 19 minutes. Okay, but follow the left, where I think till here no complete excretion. See my colleague, the complete excretion, complete clearance occur here in 38 minutes. Okay, let's see the curves. Let's see the curve. If you didn't understand what happened here, wait, please. The curve is very, very conclusive. What is this, doctor? Tell me.
This is the renogram curve of the left kidney that shows that plateau curve. Uh, Pre-captopril is the renogram
So,
pre-pharmaceutical.
so we have how many curve in renogram? Pre-captopril and post.
Yeah.
Tell me, post
Cap-
captopril. So you will present it if you presented in the exam by pre and post captopril. Keep in mind this is almost a renal artery stenosis. Okay, I told you before I have one HIDA scan and really the case was atypical and I was so confused. Finally, I told myself it must be biliary atresia. And I write everything I know about biliary atresia and finally it was correct by the way. Here also, when you are presented in any exam by two curve like this, يعني more than 90% this is a renal artery stenosis. يلا, tell us what happened here. See,
Happened here in the
one,
renogram of the right kidney, the clearance time is here as showing that the half time
one
is 10
second,
minutes, but
1 second. This right or left?
this one is left now.
No.
Right,
Right. So this,
right.
right. The blue one, my colleague, this is very important. Very important. The blue one is the right. So this is the right. Because in the exam, he can remove this words. Why? Because you should know at least the directions. And the red line is the left. By see from the beginning, where is the abnormal one side? The red or the blue?
The red
Excellent. Why? Describe. What happened?
because
What
because as written here, the start time is starting by 5 minutes and reaching the maximum at 7 minutes at the right kidney. However, the left kidney is starting late 9 minutes, is then finished by 16 minutes, and the clearance half time is 21 minutes.
Okay. Excellent.
And the area under the curve is big rather than the contralateral right kidney.
Excellent.
So it's
What happened
yes,
here? Clearance time of the left one. What means of the clearance time? The time, clearance half time. The time that the kidney take to clear half of the tracer. Doctor, how we know this, يعني, this one? By the means of the nuclear packs. They know the dose and they know how many taken for the patient and after how many minutes half of it have been excreted by each kidney. Tell us clearance half time in the left. How many minutes?
21,
21. This is and in the right one how many minutes?
10 minutes only.
So which one is more poor in the function? Which one take more time to excrete the same amount, the left or the right?
The left,
Excellent. So the poor function is here or here?
the left.
Okay, this is a pre-captopril. Okay, what happened here, my colleague? This is time to peak. This is time to peak. It should be the normal from 3 to 5 minutes. So here it is normal, completely normal. Okay, but here time to peak about 9 minutes. What time to peak? Time to get the maximum uptake. And another point here, the countess. I mean, countess mean the amount of the tracer that has been uptaken. See here, it is good, about 190, but here, see, hardly 100. So the poor function is here. Second point, see, rapid decline. This is the clearance, my colleague. Rapid and the normal. This is the normal decline. But here, slow decline. And all of these are pre-captopril. Let's see the post-captopril. Oh, okay, before we see, this is pre-captopril differential function. What mean by this, our doctor?
Differential function, I think this is related to the excretion of the uh, tubules because the red lines, red
Excellent.
dash lines below the blue line, and area under the curve of the red line is the smaller than the area of
Look here.
This is means the renal function of the left kidney is smaller than renal function of the right kidney.
Excellent. But let learn some parameters. Look here and here. The split, the differential function, it is the same as a split renal function. This is the function of each kidney. Okay. In the left is 30%. In the right, the normal one is 70%. Okay? Normally, the difference should not more than 10% between both of them. What happened, my colleague? The left one, this one, is poor function and only excrete 30% of the tracer. So the right one take the responsibility, the majority of responsibility, and they excrete the majority of the tracer. How many? How many? 70%. So the difference is more than 10%, and there are abnormality here, poor function. Okay? Step by step. Sorry if my style is slow now because this renogram makes 3 to يعني little bit complicated. Um, Look here. What is this, my doctor?
Postcaptobril.
What happened? This is the right, this is the left. Tell us. This is the post captopril. Is there are any difference between the post
No,
and the pre?
no.
Excellent, doctor. This is the most important buzzword. No significant difference in the shape of the curve of the renogram in the pre-captopril and post-captopril. But here, what do you think? Tell us what happened. This is the
This
disease
is
one. Mm.
this is uprising.
Okay. So first of all,
It's
this is the pre.
starting early. Okay.
Yeah, this is the pre. This is the post. There are any a difference? Pre post. Mm. There are any difference
Y- Yes, there is difference
in this
in
one?
timing and
Yeah,
yes.
see, one by one, one. In this one, in the left one, in the diseased one. Okay. So the the captopril, the captopril prove its positivity when we stop. Sorry, when we give a captopril, not stop, we give 1 hour after the injection is patient has been injected by the tracer. After 1 hour, we give the captopril. Then there are effect or no, there are no effect for the captopril in this kidney, my doctor. Yes or no?
Yes.
So we are running in the renal artery stenosis pathway or not?
Yes.
Sure. What
Mm.
happened to us?
Increase excretion.
No, no. This is excretion, my doctor. See? See. This is uptake. This is time to pick the maximum uptake. Then after declining from the beginning of decline, this is the excretion. Do you think here there are excretion till here or no
No,
till
it
here?
is uptake. Yes.
Excellent, excellent. Uh, Doctor, is this case has been proved to be renal artery stenosis or not, in your opinion?
Yes.
Yes. Why? Because it is there are a positive difference or decline of the function of the left kidney post captopril. Yes or no?
Yes. Even it is still below 300 per second. And the uptake is still after captopril is lesser than uptake of the contralateral kidney.
Again, please. Again.
I mean that the curve is not reaching the peak, is not reaching 300, uh, and the time of the peak is more than the time of the peak to the right kidney.
Okay.
Uh,
And here,
uh,
what about the excretion? Do you think it's
and
good excretion?
and there is no down sloping, acute down sloping of the
Yes.
late excretory phase.
Thank you, doctor, so much. You helped me يعني so much to يعني explain my ideas. Thank you. This is a case of renal artery stenosis. Where in this kidney? Which one? here. This is prone position. So this is left renal artery stenosis. What happened here, my colleague? Thank you, doctor, really so much. What happened? The normally, I will explain from the scratch again. If you understand the renogram, I think more than 70% of the nuclear is smashed. Okay? See what happened in the beginning. In the beginning, there are uptake. Then we reach, by the way, there are many phases, many names like perfusion, like time to uptake, time to execute, many. This is not important. The most important to understand what happened. Okay? What happened? There are uptake. The time to peak. This is the first most important. The time to peak. It must be between 3 to 5 minutes. Okay, this is the time. This is the count. What is the count? Hey, this is the count. Count means the percent of the tracer dose. Okay. What happened here? The shape of the curve. This is the normal one. 5 minute time to peak, and then decline of this is denoting excretion. First parameter time to peak 5 minute, 5 minutes. Second parameter, my colleague, is time to have. What is time to have? The time needed to excrete half of the tracer. It should be less than 10 mm. From here to here, look, less than 10 mm. The most important, not the parameter in comparison to the shape. After 5 minutes, you should start to excrete. The curve must decline. Even gradual, sharp, the most important decline. Okay, this is normal. Okay, but what happened here? Let's start from the first. What happened? The kidney, this kidney originally is diseased kidney. The renal artery is stenosed, so it is poorly perfused. What happened? The blood is not adequate. So poor blood. Time to peak, time to peak is about 9 minutes. In addition, it is very poor peak. This is the maximum effort of this kidney, maximum ability to uptake. So why the normal look here? So we must compare. In my opinion, as we are radiologists and we are not a nuclear medicine specialist, they must give you only unilateral renal artery stenosis to compare with this one. I think this is the logic scenario. Look here, the uptake is very good, adequate, about 190, but here this is 100. Okay, so time to peak here is very long, and the peak is very poor, about the half. Then the decline, see, very slow. Look here, time to halve here. This is time to halve. Less, it should be less than 10 minutes. Here, look how many? 15 minutes, very long. And the curve itself looks like a plateau. This is a pre-captopril. Why we should do a post-captopril? Because captopril block the angiotensin renin mechanism. So it will disclosed the compensatory mechanism in the diseased kidney. What happened here? The artery here is stenosed. The same. Look here. Poor uptake. But poor uptake. But gradual uptake. What happened? About 23 minutes, the kidney is still uptake. Incredible. Very lazy kidney. This is very lazy. Look here, about 23 minutes, the kidney uptake to 250 counts. It take more than 20 minutes. Incredible. And no excretion because it retained the counts here, the tracer. Why? It is lazy poor kidney. But what happened here? This kidney in 5 minutes exceeded the uptake, very active kidney. Uptake more than 300, more than 300, very active. And then immediately, this kidney is very active, has a lot of work. So it must excrete, rapid excretion. She has a lot of work, a lot of task of today. So this kidney must excrete about 10 minutes. Half of the counts or the tracer has been excreted, and then the rest. Very good, very active kidney. Okay, my colleague, sorry to use this layman language, very simple language, but I think it is better to to facilitate this all parameters and the complexity of renogram max 3. So, doctor, what happened here? Let's talk in the radioactive isotopic buzzword. What happened here? Prolonged, significantly prolonged time to peak and persistent or retention of sorry, not contrast, the isotope here with very slow excretion. All of these are signs of renal artery stenosis, especially post-captopril. Okay, my colleague, anyone has any question? This is, in my opinion, the most difficult part in the nuclear. This is in my opinion. See here, the clearance, half time to clear here, very long. Look here, very long, very long. Okay, my colleague. There are other parameter, but I think no need now. Anyone has any question, my colleague? Why clearance time is increased in both? Okay. See, generally speaking, the normal kidney will not affected by the captopril. Okay, will not affected. The only one that affected the left one. Despite there are an answer for your question, but let us concentrate in our target. Okay, there are this question has an answer, by the way. The normal kidney may be a little bit affected, but look here and look here, which one is maximally affected? The diseased one. Okay. For more details, my advice for you, if you want more details, after finishing FRCR exam. Okay. This is for our benefit. Second, one friend asked, the friend that asked about the difference between pre and post captopril kill. Okay, my doctor, see, again, the most important point that I want from you. This is the pre captopril. No captopril here. No, no captopril. Look here at the normal. This is the post. Look here. Do you think there are a big change? In my opinion, no. Look here. Look here. Overall, no. But look at the red line. See, this curve is uptake and start to excrete. But this curve, a big disaster. What happened? This uptake. What? This is a disaster here. 23 minute only uptake. Why the captopril stop the compensatory helping angiotensin renin mechanism? Okay, so it become not a poor kidney, it become a miserable kidney. Okay, is this clear, my doctors? Look here, this is the pre. Okay, uptake, delayed uptake, and poor excretion. But here, disaster, continuous uptake, and almost here a plateau. If you find a difference between the two curve, if you find like this, it is a renal artery stenosis. According to the FRCR, most of the parameters you are not requested to tell, but I'm telling for all of you to to understand everything. If you retain some of them, it is good of you. But at least if you told the examiner, doctor, this is the pre and this is the post, okay, and there are a deterioration here or there are a big difference, a worsening, okay, doctor, so it is an evidence of renal artery stenosis. Okay, my colleague. Next candidate. Hello. Next.
Yes, sir.
Next candidate. By the way, this is the normal one. See my colleague. This is the normal renogram max 3. Sorry, doctor. Keep online 1 minute. See my colleague. This is the pre. What happened? I think the left one is similar to the right one. What happened here, my colleague? See, time to peak is from 3 to 5 minutes. This is one ideal renogram max 3. And what happened? Uptake, then decline. Uptake, then decline. And at 20 minutes, this is one of the most important, complete clearance. See? In most kidneys, from 15 to 20 minutes, you must see no any, see here. This is the photos. Here. See here, my colleagues, about 21. Is this like this? Like this? No. So the complete excretion start or happen here at 20 minutes. A second point, sorry, compare the pre with the post. Compare the left with the right. The left is similar to the right. The pre, the pre looks like similar to the left. Okay, looks like. In my opinion, uh, they will not give you a bilateral renal artery stenosis. It will be very difficult for radiologist. So compare each kidney with the other side. It will help you so much. Even here, this is differential or split kidney function. What happened here? One kidney is 51. One kidney is the other one is 49. 49. The difference between both of them should not more than 10. Okay, my colleagues, this is the normal MAG 3. Next candidate,
Yes, sir.
25-year-old male patient presented with recurrent flank pain. Go on.
Sir, I'm provided with the nuclear scan images, and I could appreciate that there is a normal uptake noted in the left kidney, but there is slightly decreased uptake noted in the right kidney.
Are
I
you
would like to,
one second? Are you sure there are any decrease at both of them?
sir, yeah, there is a difference. I
What?
think there's,
Tap.
I think the difference
Look.
in uptake of both the kidneys.
Okay, look here. Tell me what happened.
Sir, I'm provided with renogram images of both the kidneys, right and left. According to these, there is a normal time to uptake,
Excellent.
and
Normal
there,
to have and normal.
yeah, normal excretion.
There are any difference between this and this or not?
No, no, sir.
Clearance have time. Here is 7. Here is 4. The normal must be below 10. So this is acceptable or not acceptable?
But this is then acceptable because there is a difference of three
Excellent.
units.
This is the differential or split kidney function. See?
Yeah, so the differential
It's
function on
tell me. Yeah.
50, so
Mm.
it's equal on both the sides.
Mm. And the abnormality start يعني the number, the benchmark of abnormality till how many percent?
So more than 10.
Excellent. So this study, tell me,
that there is no difference in both the functioning of both the kidneys.
so
However, I would like to post captopril.
this patient has no hypertension, by the way. Okay, this
Okay.
patient has left BUG obstruction, old, and has underwent a pyeloplasty.
So, sir, that means it's working fine.
Excellent. So what do you think? This normal or abnormal?
So normal, as there is
Excellent.
difference is less than 10 minutes.
Excellent. So this is normal. What happened? Time to peak less than 5. Time to have here, here. Clearance half time less than 10. Okay. And both kidney are even similar. Okay. So it is normal. Thank you, doctor. Thank you so
Okay, sir.
much. Next candidate.
Thank you, sir.
Welcome.
Hello.
Welcome. By the way, you will not present it with a normal case at all in the exam, but just I bought this case يعني just for confirmation of my introduction. Doctor, this is a child with recurrent urinary tract infection. Go on.
Okay, these are uh, MAC technician 99M renal scintigraphic images. I can see that the contrast uptake, radio tracer uptake is seen in the left kidney. However, in the right kidney, I couldn't see any radio tracer uptake.
I think.
I
Okay. Yeah, tell me. Yes, yes, go on.
uh, and I am looking for the urinary blood. I need to see the renogram curves also. Because only the kidneys are seen in these images. Is this scrollable? I think this is the scrollable image
Excellent.
because
I'm
we
waiting.
got image.
So one second. I'm waiting for you. This is scrollable. Do you remember my colleague, the mistake that I committed before? Hey, see, this is scrollable. Scroll. What happened? Yeah, tell us. There are uptake here. This is right or left?
This is the left.
Okay. And what about the right?
On the right, radio tracer uptake, there is poor or almost no uptake, radio tracer uptake in
What
the.
happened here?
Okay, in this, the a normal radio tracer again uptake is seen in the right kidney without showing, sorry, left kidney without showing any regions of cortical scarring. And also I can see the excretion because I can see the tracer activity in the right ureter, sorry, left ureter. On the right kidney, it shows poor radio tracer uptake and it gradually increased uh, along its in the lower down images. The normal activity is seen in the urinary bladder.
What happened here, my doctor?
Okay, these are renogram curves of the same patients. I am looking for the, this is the perfusion image.
1 second.
Um,
Before you start, you
altitude.
must know right from left. The circle one is the right. Where is the circle one? This one. See, this is very important. So this is the right and this is the left. Which one is the abnormal? Right?
So right, yeah, right one is abnormal because
Oh,
it shows
oh,
less radio tracer uptake and there is no clearance of the radio tracer uptake. Rather, it shows gradual plateau. It shows plateau as compared to the normal left side, which shows peak, and that shows a peak at the higher uptake activity, and also it shows rapid washout. The normal left kidney. However, the right kidney is a poor functioning because there is no excretion of contrast. That is plateau, and also there is less radio
plateau.
tracer
Oh, so
activity.
1 second. You mean this is plateau. Okay?
Yeah.
Plateau. Okay?
Yeah.
So there are poor uptake and persistence of the tracer. Nearly no excretion. Plateau. Okay? And then what's your differential diagnosis here, doctor? See? What's your
Sir,
differential?
Yeah, in my differential diagnosis could be obstructed kidney because
What?
on the previous
What?
images I could,
What's your differential again?
it could be obstructed kidney.
Excellent. How to differentiate between both type of obstruction? How many type of obstruction do you know?
These could be obstruction could be due to baggy pelvis or due to PUJ obstruction.
Okay, okay, but we have two big titles: mechanical obstruction and non-mechanical or pseudo
Okay.
obstruction. Okay. If we give Lasix in mechanical obstruction, it will not affect the curve because it is actual or true obstruction. But in non-mechanical, like megaureter, like stasis, like this, when you give
That
Lasix,
depends.
this curve improve dramatically. What is your next step? This is a child.
Diuretic after this, the diuretic renogram to see the changes in the curve,
Okay,
whether there is
they
or
give
not.
they give diuretic and they not change. What is your next investigation?
Okay, I can help from the ultrasound
Ex-
and
Excellent, excellent. See my colleagues here, the time to peak at the diseased kidney, the right, is triple of the normal. Okay, the half peak time, this one no peak here, no peak. This is the split renal function. See here, 75 here, 25, big significant difference. Okay, يلا tell me your diagnosis, please. This is
sir, these grayscale images, the left kidney is normal without showing any pelvic lesion dilatation or hydronephrosis. However, in the right kidney, there is a gross, there is a moderate to gross hydronephrosis and also ballooning of the main renal pelvis, showing weak-like
what's your
appearance
diagnosis,
and
doctor? Your
PUJ
diagnosis.
obstruction. This is a case of PUJ obstruction causing compromise of the renal function of the right kidney.
Thank you, doctor.
So, so
Thank you.
this patient needs sorry.
Yes.
Further, should I say a few words about management or not?
Sure. Pediatric urology for surgical correction.
Yeah, and also pyeloplasty for the
Okay.
pyeloplasty because still there is 40% function of the right kidney.
Yeah,
So
sure, sure.
definitely.
Thank you, doctor. Look, my friends here, the obstruction curves. This is the obstruction, mechanical obstruction. If you wanted to give something, not captopril, it will be Lasix. So, see here, see my colleagues, Lasix injection. Look here, Lasix. What I mean by this? If you see a renal scan max 3 with Lasix, put in your mind it must be the diagnosis obstruction, especially if the patient is young age, almost it will be BUG obstruction. If you see an adult renal max 3 with captopril, 90% the case will be renal artery stenosis. Don't confuse yourself. I think it is very easy. Okay, my colleague? And about too much dilemma, too much details, I think, in my opinion, most of the information that we are saying you are not requested from you. But but I'm explaining the general the background. Okay, because if you get a good background, you will never mistake the case. Okay, my colleagues, thank you so much, my doctor. See here, my colleagues, here I think here he gave Lasix. What happened here? The normal one excrete more here, but the abnormal one is still in plateau. No any affection. No any affection here. Okay, my colleague, Lasix is here. See, the abnormal one, a persistent plateau. The normal one, more excretion. Thank you, doctor, so much. Next candidate.
Yes, good evening, sir.
Evening. 45-year-old female patient has abdominal pain.
Okay. Um, I have a nuclear medicine study of the kidney urinary bladder.
Okay.
At both yeah,
If I
at
show
both
you, see, if I show you this curve, this is dynamic or static?
this is dynamic
Excellent. What's the type of tracer?
metric.
Excellent. Look at the curve first because still we are in the beginning. What do you think? There are any big difference between right and left? See, this is the left, the green one. This is the right.
Yes,
Do you think the both curves are different or overall similar?
they look to have the similar pattern. They take
Excellent.
about the same time to peak, just that one peak higher than the other.
Okay, okay. But generally, see, one peak is about 7K. This is a count. And
Uh-huh.
the other one is 8K. Okay.
Okay.
Like two different rich men. One have three big companies and one have only two. Not poor like
Okay.
us. See, see here, the left kidney split function is 49, the right one is 51. Do you think this is normal or abnormal?
The only 2% difference. I think it's can be normal. No.
Normal, excellent. Let's go again here. Do you think the uptake here in the first 5 minutes, there are a big difference?
No, it appears same in
Okay.
the first.
Okay. After 9 minutes, what do you think? There are
The
any
uptake
difference?
on the right, sorry, the left kidney has cleared more, whereas the
Okay, but
right kidney
see,
shows more retention.
but generally, because we are not expert in nuclear, generally there are big difference or there are any poor kidney of both of them?
Okay, almost the same.
Okay, so this case, do you think this is normal case or abnormal?
I think normal maybe.
Excellent. Excellent. This is, yeah, this is a normal max 3, another normal. I am trying to repeat the normal to fix the information. Repetition is very useful in this nuclear scan. Thank you, doctor, so much.
Thank
Next
you so much.
candidate. Next candidate. This is a child has abdominal pain. Look here. Next candidate, are you ready?
Yes, Dr. Hi.
See my colleague. This is a supine. This is supine. This is prone. Concentrate. See my advice for all the attendants. My colleague, first, look at the most simple photos in this nuclear. If I am in your position, I will not start with this. I will start with one single here, and I will try to look and get some information and here, and finally here. Okay, doctor? Could you tell
Okay.
us what happened?
So this is the MAT3 images.
Why not
Is this a
themselves?
child? A child?
This is dynamic or static?
MAT3 is dynamic.
And here, timing.
Yeah, there's timing here. Yeah.
Okay. So when
Yeah.
you see multiple photos like this, okay, here no timing, just the number of the photo, 1, 2, 3, 4. Okay, but it is more than 20, 26 images, so it must be dynamic. What happened here, doctor? And here,
Okay, so I can't see the right kidney uptake in the right renal fossa, while the left kidney is seen in its anatomical position, and there is another uptake down inferior to the lower pole of the left kidney, which
yes,
might likely represent a right kidney in ectopic position.
Island.
That's
And what
my
happened?
first.
What happened?
Yeah, and they are continuous
I think the parenchymal uptake is continuous.
What's the
So
name
this
of
is
this abnormality?
crossed fused ectopia, renal
Thank you,
ectopia,
doctor.
most
Thank you.
probably.
What is the complication of crossed fused ectopia? Crossed fused ectopia. What is the complications?
Maybe obstruction, hydronephrosis, maybe
Infection.
more liable or
And
and infection due
okay.
to the kink of the ureter.
Thank you so much. My colleague,
Okay.
my advice for all of you, any case of nuclear, either in long reporting or in Viva, is very to be smashed. Okay, my colleagues, very easy. Why? Because there are some basics. If you study it well, I think you will never mistake any case. Next candidate.
Assalamualaikum, sir. Next candidate
M.
is
65 male, 65-year-old male patient with hematuria.
yes, okay, sir. Sir, I'm provided with the ultrasound images in which I can appreciate that in the right side there is a severe hydronephrosis in the right kidney, which appears to
Yes,
be atrophic,
yes,
small with cortical thinning. And I don't appreciate an obstructing any calculi, but there's a severe hydronephrosis with cortical thinning and atrophy with reduction in size of the right kidney.
excellent.
Uh, and as compared to, I also want to check left kidney, sir, contralateral kidney.
This is the left.
Uh, yes, sir. Left kidney is a normal size with the SH no gross abnormality, but right kidney is atrophic with severe hydronephrosis.
Excellent. See, doctor, they do
Yes,
not
sir.
CT. They do this one.
Okay, sir.
This-
Okay, sir. Sir, these are the static images of a DMSA scan,
Excellent.
in which I can appreciate there is no uptake of contrast noted on the right side,
Yes,
which and however the left kidney shows normal uptake, and so sir, there is no cortex remain in this kidney. This complete loss of cortex. That's
yes.
why DMSA scan is not showing uptake on the right side.
Okay. So
Yes.
they do the CT.
Okay, sir.
Look, see, I will help you. This is the post contrast.
Okay, sir.
This is static images.
Okay, sir.
Static images. See,
Static images. Okay, sir.
they
Okay.
measure
Okay.
something here in this. This is a psoas.
Oh,
This is a
so
psoas.
Smith.
There are something
Yes, sir.
here. Tell me what
So this
happened.
is probably the right ureter. I think it's due to prolonged obstruction. It may lead, I think, chronic
Yes.
obstruction that leads to severe loss of renal cortex on the right side.
Excellent, excellent. Really, really excellent. Look, what happened here?
Yes, sir.
This is the left
Yes.
ureter. This is the
Yes,
right.
sir.
There
Yes, sir.
are,
Yes, sir.
tell me,
Yes, sir. There is a normal delayed excretion on the left side, but on the right side, there's no contrast identified within the ureter. So there's an absolute obstruction on the right side. Even not a trace of contrast is seen in the ureter. So kidneys appears to be non-functioning.
okay, look here.
Okay, sir. Okay, sir. They also do the ascending ureterogram, in which contrast is given to the ureter through the cystogram, in which there's a severe hydronephrosis on the right side with kinking of the ureter on the right side. Yes, sir. The selective ureterogram on the right side there.
What is this?
Yes, sir. So there's a large filling defect identified in the
Brilliant.
proximal or mid right ureter, which
So
leading to severe hydronephrosis.
what's your final diagnosis?
So there's a long-term chronic obstruction due to a large ureteric calculus, which leading to loss of cortex of the right kidney and loss of function on the right side. So this is a complication of long-term chronic obstruction
What is
due
the
to calculus.
obstruction? You didn't give me a differential for this filling
Okay,
defect.
sir, differential. Oh, sir, so differential could be, sir, and possibility of some
malignant neoplastic lesion can also be possible. Urothelial transitional cell
Thank you, doctor, so much.
cartilage,
What
or
is the
sometimes
what is the most
slugging.
what is the most important for you as a radiologist about transitional cell carcinoma? What is
Sir,
the
these are these are synchronous lesions. They
ex-
also seem to be involving the bladder as well as some ureter
Thank you,
and renal
doctor.
pelvis as well.
Thank you doctor, so much. See, my doctors, all the patient has hematuria and very important the history. And we have non-functioning. Doctor, remove from your brain BUG obstruction at all. يعني according to the age from the beginning, and then start step by step build your provisional diagnosis. No excretion here. This is anterior, my colleague. This is posterior. Our doctor did very well when from the beginning see anterior posterior anterior posterior. Oh doctor, this is very few images. It looks like DEMSA. Looks like DEMSA. Okay, static, non-dynamic, very important. And then the CT show us here. My colleague, I have been presented by many static images in the FR. Many. Okay, there are many kind examiner really inside. Many, and the pathology was very clear. Anyway, and finally we diagnose by this is ascending ureterography. I think this is done by endoscopy, see, cystoscopy. Thank you so much, my doctor. Next candidate. Next,
Yes, sir. Yes, doctor.
welcome. This is
Yes, assalamualaikum.
a 75-year-old male patient presented with pneumonia and cough. Go on.
All right. So, I'm presented with a chest X-ray frontal projection of a skeletally mature patient who
Yes.
presented with cough and pneumonia. On the first instance, I can see that there is mild inhomogeneous airspace opacification noted in the left lower lung zone, with mild haziness noted at the medial left hemidiaphragm. There is
Mhm.
also mild blunting of the left CP angle, suggestive of mild diffusion.
Yes.
Um, However, no definite air bronchograms or consolidation is seen. Um, there is a sclerotic anterior rib noted on the left side. I count it is one, two, three, four, fifth rib. Interior appears mildly sclerosis. In an elderly patient, this inhomogeneous opacity, mild proliffusion, mildly sclerotic rib. I am concerned about any underlying mass lesion, could be bronchoalveolar carcinoma. So I will like to proceed with the CT
Doctor,
thorax with IV contrast.
doctor, where is your area of concern? Where?
Left lower lung zone.
No. What
No.
else?
What else? It could be the both lungs show normal
Don't
inflation
don't worry
and
about the lung. What else?
rib, the sclerotic rib,
Where?
this fifth anterior rib on the left side.
Okay. So what's your differential?
My differential could be of in an elderly patient could be of Paget's disease or a sclerotic metastasis.
What's your next step?
Next step would be bone scan or CT scan.
What happened here? Tell me.
Yes, so I'm presented with MTP bone scan, anterior
Yes.
and posterior images. Here
Yes.
I can see that there are multiple areas of uptake seen in the spine,
Yes.
patchy areas. There is also diffuse uptake seen in the interior part of the left fifth rib. Um, this in an elderly patient could represent Paget's disease. However, I can also note a
Are you
note of
sure?
focus of increased uptake.
1 second. Are you sure this is budget? Look again. We have
Yes, I think it's the metastatic disease because we have multiple uptake in the spine as well as in the right femur,
excellent.
uh, in the mid distal part.
What type of metastasis? Could you guess the primary?
It's a osteoblastic metastasis. If the patient is male, most likely it is from the
Do you
prostate.
remember the history?
Yes, it was a male patient, I think
Oh,
cough pneumonia 70 something. So it's most
excellent.
likely due to prostate cancer
Excellent.
or
Thank you, doctor, so much. Doctor,
something.
what is your next step?
I will immediately convey my findings to the referring clinician and will advise PSA levels and also MRI of the prostate gland for local
Why?
staging.
Ultrasound first. Ultrasound. We don't know. Okay.
Okay, yes.
Yeah,
Okay.
ultrasound.
PSA
Doctor,
levels and ultrasound, yes.
if your colleague, the oncology colleague or urology colleague ask you this patient, he want to do a PET CT. He has been proven to has a prostatic cancer. What would you advise about the PET CT? Which type of PET CT?
It is PMSA, prostate antigen specific
Excellent. Gallium plasma.
gallium plasma.
Gallium
Yes.
plasma. Okay. If after this patient, after some bounces, your colleague also want a consultation from you, he want to do another PET CT to detect a recurrence of a treated prostatic cancer. What what is the type of tracer?
Yes, it was different.
Yes.
Yes. I couldn't remember it at the
Choline.
moment.
Choline. Okay.
Coli.
Okay. What is the most common tracer in PET CT? The regular one.
What? Sorry.
What is the regular tracer or the most common general tracer in PET CT?
General in PET CT is FDG.
Okay, 16 FDG. Thank you, doctor, so much.
Thank
Very
you, sir.
well. Uh, See, my colleagues, if you see the lung looks like normal, don't waste the time. Search immediately in the review areas. Okay? And when you searching in the review areas, my advice for you, compare. If our doctor is one example of all of us, okay? If we present it with this case, we will miss this one. Why? Because most of us look here separately and look here. No, look at the rib, upper rib here and compare here. Look at the middle and oh, okay, there are a difference. Okay, there are a difference. The comparison is the key. The comparison is the key for all MSK, even in ultrasound. Okay, my colleagues, thank you, doctor, so much. Sclerotic rib, and then sclerotic metastasis, and she discovered or she gave us a prostatic cancer as a differential. Thank you, doctor, so much. Next candidate.
Assalamu alaikum, sir.
Salam. This is adult male patient presented with generalized bone ache. Go on.
These are two images, frontal and posterior view of bone scan in an adult male patient, in which I can appreciate that there is bilateral symmetrical periosteal uptake along the both side of tibia, fibula, and femoral region, both in the anterior and posterior views. Also, I can appreciate that there is no uptake in the kidneys. So I
Really?
believe that this is a super scan. There is also a very symmetrical type of uptake seen in the whole of the vertebral region in the posterior images.
Hmm.
Also, I can appreciate that in the skull region, there is a Abraham Lincoln sign, which is quite
Amazing.
consistent.
Amazing. Really, really. Go on.
which is quite significant for the symmetrical bilateral uniform uptake seen in the Paget's disease in whole of the mandibular region as well as in the maxilla. So the whole picture is quite suggestive of a uniformly distributed metabolic disease, which is Paget's disease, with a super scan type of picture. I would like to correlate with the X-rays of the patient, whole bone skeletal survey with the alkaline phosphatase level with the previous imaging. Also, I would like to communicate the findings to the referring physician for follow-up because this disease has a predilection for malignant potential. So my conclusion is super scan with Paget's disease.
With what?
Paget's disease.
Are you sure? Is budget, doctor, is budget is very symmetrical like this? Extremely symmetrical?
Sir, there is a possibility that this can be two diseases going on.
What else?
The mandibular disease was quite consistent with the Paget's disease, but the
No,
femoral and no,
no. The budget, see, look here. Look here. Is this the expansile features of the budget? Is this budget is not symmetrical like this? Doctor,
yes, it's
when you see something very symmetrical, bilateral, affecting upper and sorry, lower and the upper limb, what come in your mind?
sir. This bony uptake was first suspicious for hypertrophic osteoarthropathy, but then
No,
the
no, no. One second, my doctor. Follow me, please. Follow me. See, my colleague, the most important in Viva, not the knowledge, the style, the logic style. One by one. This is a super scan. Great. Where is the prediction? Is this this is super scan? Where is the maximum uptake? Is this in
a,
the axial or in the peripheral?
a peripheral appendicular.
Okay. How many diseases that we have in the periphery affect cause a super scan?
In the periphery, there are
Two.
metabolic
What?
diseases.
Yes, metabolic and the budget. Okay. In
Hmm.
your opinion, can budget come with this amazing, incredible symmetry? Upper and lower limb, incredible symmetrical.
No.
Okay. So exclude budget. And
Okay.
by the way, there are many signs against budget. So we are thinking in
We are thinking in
metabolic.
hypertrophy, metabolic.
What?
Hmm.
Which metabolic disease?
For a
By the
diffuse,
way, by the way, hypertrophic pulmonary osteoarthropathy is not a metabolic disease. By the way,
it is
metabolic means metabolism, either enzymes, hormones, a big difference. So
so,
I
sir.
show you this. What happened here? Here.
It is,
What is this? See, see. What is this?
sir. This is a ring and arc type of calcified lesion, exophytic in the right ileum.
Yes, yes. What is this?
Sir, this looks like chondrosarcoma or
What happened here?
sir, this is a cotton wool type of appearance in the skull with expansion of the diploic space and multiple lucencies, ill-defined outer and inner diploic outlines.
Is this the cotton wool, doctor? This is not a cotton wool. This is not a cotton wool, doctor. Doctor, look again. And don't worry, by the way. Don't worry. Is the cortex here is thick or not?
No, it is not thick.
So it is not a Paget disease. We exclude.
Okay.
Look here also. Okay, look here. Something who has been transplanted here. We has transplanted here and then it is rejected. What is this?
Transplant kidney rejection with calcification.
Okay. So, so what is this? What is what is this?
Renal osteodystrophy
Excellent. So this is a super scan due to
due to renal osteodystrophy.
okay. Thank you, doctor, so much. Don't worry. Uh, take some message from me. Doctor, my advice for all of you, when you see a bone scan, first thing, look, is this super scan or not? And tell the examiner, I can or I can't see the kidney and soft tissue. Or like in this case, doctor, I can't see the kidney at all in AP and the posterior, and even no uptake in soft tissue. Doctor, this is a super scan. From the beginning, you are in the correct pathway. Then, in all bone scan, my colleague,
Sir, why
especially
was there symmetrical
what?
Sir, why was there symmetrical bilateral uptake giving in both tibia and femora? Is it happen? Does it happen in renal osteodystrophy?
Listen to me 1 minute and I will answer everything. Listen, okay? What happened here, my colleague? We didn't find. And then look, from the beginning, as I told you many times, look generally and choose which pathway you will run within it. This is this is not a localized uptake. This is a generalized. So you are talking about a general systemic disease. And this is the first, but this is in your mind. You will start from absence of the kidney to tell the examiner the super scan. And you will tell him, doctor, the uptake is mainly peripheral. By the way, there are some uptake in the spine, but mainly peripheral and symmetrical and no expansion. No expansion of the bones, long bones, or no obvious cortical thickening. By the way, no periosteal reaction here, like to exclude for you, my doctor, this is not a case of hypertrophic osteoarthritis. And then, doctor, it looks like due to metabolic disease. The most common is hyperparathyroidism. Whatever the cause, whatever the cause, what is the most common cause of hyperparathyroidism in UK is renal failure. In UK is renal failure. So this is almost renal osteodystrophy. I will revise or I will do X-ray. What happened here, my colleague? Transplanted kidney. And what happened here? Osteopenic texture. Overall, this is osteopenic. And there are, somebody will tell me, doctor, there are coarsening of the trabeculae. This is with in the side of budget. No, one of the most important sign of osteopenia is the coarsening or the what mean by coarsening of the trabeculae, because most of us really didn't know the depth of this word. Coarsening means that it is visible, yeah, just visible, because the normal bone you will not see the trabecula like this. Why? Because um, there are calcification. So all the trabeculae are obscured. This is the normal. This is coarsening, but without expansion or cortical thickening. So there are no other no signs of Paget disease. And this, my colleague, this is a salt and pepper appearance. This is not cotton wool appearance at all. See here, very small, tiny hyperdensity or opacities. Here, and lucent, alternative lucent. This is the exact salt and water appearance. Beside, the cortex here is thin, by the way. This is very obvious. So here, no obvious Ruger jersey, okay? But you will not present it with all signs. So, my colleague, it is a case of renal osteodystrophy, metabolic super scan. Okay, my colleagues, let's take rest 5 minutes because really my voice is go out.
Thank you, sir.